Brenda is the manager of QUIP, and I had to get the pronunciation correctly, so there's no U there, but it's the Quality Improvement and Innovation Partnerships, and I think it really talks about the transformation in a very focal way of primary care in Ontario, and I think both the complexity as well as the promise that it holds. So I look forward to hearing what you have to say. Brenda, welcome.
It really is a great pleasure for me to be here and to also have an opportunity to follow on the presentations that Mike and Eileen gave you. It's really a perfect sort of tee up for what I want to talk to you about. They've certainly talked to you and hopefully excited you about moving to this new opportunity of the way that care is delivered, and giving you some examples of how it's worked in other places. So what I'd like to talk to you about is what we're doing through the Quality Improvement and Innovation Partnership to really try and launch this type of an approach in the Ontario context, specifically with family health teams. So what I'm going to do is just provide you with a little bit of context for the work of QUIP Learning Collaboratives, talk to you about family health teams specifically. I know most of you are from family health teams in the audience, or many of you, but I know there's some other participants here from other parts of the system. So just wanted to give you a little bit of background and talk a little bit about the organization that I work with that has been put in place and funded by the ministry to support family health teams in Ontario. And then talk specifically about the structure, the content, and the components of the learning collaboratives that we're operating. So again, that you have a bit of a sense of, how does that all hang together, and how do these great concepts that you've heard about, how would I actually learn about them and be able to apply them within our setting. And then I have a short video to show you that really, I think, wraps together the concepts that we've been talking about as part of the panel this morning, and hopefully gives you a good sense of the difference that we think the approach can make for both patients and providers. And hopefully I'll cover that all in 15 minutes. So just by way of introduction, there are 152 family health teams that were funded in 3 waves across the province, and they're in various stages of implementation, but certainly we're well along in the process of seeing teams funded and up and operational, and there actually are 141 now that are fully operational, and a few more still just in those final stages of getting up and running. As probably most people know, 50 more have been earmarked to be funded in the next 2 years under the mandate of the existing government. So they are yet to come on stream. Usually, family health teams are really quite different. I think we learn that more and more all the time when we interact with teams. But typically, they may have 3 physicians. That would be usually the smallest, up to an average of 25 family health teams. But in some, there are huge teams. There are several that are really, really big fits, Barrie, Peterborough, and Hamilton, and they have upwards of 60 to 120 physicians that are part of those teams, along with all the health professionals that have been recruited and are working with them. So lots of variation and lots of exciting differences and opportunities to learn from one another. They operate under 3 different governance types, provider, mixed, or community, and they're really there to provide comprehensive care to rostered populations, and certainly targeting individuals and families without physicians was a key part of the strategy. So many are aiming to increase their roster size and their ability to serve orphan patients. Tend to be staffed by an administrator, dietitians, nurses, health educators, nurse practitioners, social workers, and mental health professionals, physicians, and pharmacists. That's kind of the typical makeup of a family health team, although some do have other health professionals working for them, and certainly the front office staff and administrative staff are key parts to doing the work within this team-based model. The FIT model itself is really, in our view, comprises 6 elements or features. As they move forward, we hope to see these as core parts of what family health teams are all about. Clearly, team-based care, the population approach that both Mike and Eileen alluded to, looking at quality improvement as core to what they do, being able to do performance measurement, seeking community partnerships, and always looking looking to ways that they can work together, and really bringing the patient into the whole experience of how they are engaged in their care. Through this kind of embracement of these features, we feel that we're going to see more and more well-functioning teams, strong organizations, and high-quality care being delivered. FITs are on a journey. They're new organizations, and so they've certainly got lots of work to do to go from being approved and funded to actually embracing those features that I just showed on the previous slide. They've got lots of foundation work to do, and many are still on this journey of looking at HR and recruitment issues, putting in place those structural organizational frameworks around their governance and how they work, and then clearly IT, space, and partnership issues are a big part of what they need to get in place to then move to that next level that really involves building teams and delivering programs. The final piece that we see as being key to their work is really determining how they can improve the quality of care. So tall order for FITs, and so that's where QIP comes in. As I mentioned, we've been funded by the ministries to support FITs to get there. And we certainly are involved in helping them develop and evaluate programs, assisting with the integration of new health professionals and helping them build teams, looking at how they can best link with community partners, and then improving the way that care is delivered and looking at organizational frameworks that may support all these things. And really what we want to see happen is make them successful at negotiating the transition to a new model of care. So this picture is small, but it's part of a framework document that we have that tries to pull all the features together and talk about what is in the center, which is what FITs we feel are all about. Hope it's on the screen. And then the kind of supports that we can offer through QIP to network FITs and help them connect with one another and learn from one another, to provide them with resources and supports that may allow them to tap into information that's there that they don't need to recreate or can be apprised of. And then finally, to help them really adopt improvement methods, which really goes back to a lot of what Mike and Eileen shared about this approach to moving to proactive plan care and how you get there and how you use quality improvement to really make it happen.